Dr. Vijay Yewale, sir, to take the session ahead. Welcome, sir.
Very good morning, all the accordions, and thank you so much, Dr. Nidhi, for those words of introduction. And after that, very crisp opening remarks, taking us back to 2016 and walking us through the journey of Accord in last 6 years. It was really nostalgic. However, unfortunately, because of the COVID circumstances, no longer are we able to meet physically. But you accordions have created niche in the hearts of all the faculty members. And here we are once again with you to conduct the accord this year. And let me tell you, my dear viewers, that this year we will have a series of 2-hour webinars, one every month, so as to meet with the demands of our accordions, come up with topics and subjects which are of interest to them in their day-to-day practice. And as Dr. Nidhi said, keeping in mind with the current situation, we thought let us have some crisp talks by the most sought-after expert faculties in this field of pediatric infectious disease and vaccination. While it is a great pleasure to share the podium or the dais with my close friends, Dr. Bala Subramanian, Dr. Nitin Shah, and they are also my guide and mentors. I get little jittery, talking ahead of them. So with this few words, let me start sharing my screen. And thank you, Dr. Nidhi, for that wonderful Saraswati Vandana, which has really set the ball rolling for knowledge sharing. I will be talking on managing acute febrile illness in COVID-19. Friends, all of us are aware that acute febrile illness is the most common reason to visit a doctor. And we are in the midst of COVID-19 pandemic. And COVID-19 is an acute febrile respiratory illness. However, we also know that some patients do not have respiratory manifestation. And it could just come with fever without focus. And the monsoon has almost hit all parts of the country. And we have already started seeing cases of the routine acute febrile illnesses that are so very common in tropics like India. To list a few are dengue, chikungunya, malaria, influenza-like illness, scrub typhus, leptospirosis, and our evergreen hero, typhoid fever. And to add to the list, and you know that the clinical features are so overlapping that it is very, very difficult to rule in or rule out COVID-19, given the implications that it has with respect to managing these AFIs. At the same time, one just cannot afford to miss out on our, regular tropical infection that we see. And to add to the basket is your multisystem inflammatory syndrome. And Dr. Bala Subramanian will elaborate on this entity and guide us on the best rational management of this disease, including suspecting and diagnosing it and offering the best possible with the constraint that we have across the country. What is posing a dilemma is, as we are growing in pandemic, more and more children are becoming seropositive for COVID-19, SARS-CoV-2. And it is definitely posing a dilemma with a risk of over or under diagnosis. We are getting cases of fever where, as a routine, you do your SARS-CoV antibody and the child is positive. And then it becomes a challenging task to just delineate a true causal phenomena versus just a bystander antibody. However, let us not forget our basics, that when we approach a case of acute febrile illness, what is of most importance is a thorough history and physical examination, which should guide you through a few investigations, which would confirm the diagnosis that you have entertained based on your detailed history and examination. Now, we know that when we get a case of acute febrile illness, it is very important to know the background setting, and you need to add some information in terms of history and clinical examination, and then arrive at a working diagnosis. If you follow this algorithmic approach, I'm sure most of us would be very rational and would not miss out on important entities. When I say background knowledge, it is important to know the immune status of the child, because if you have an immunocompetent child coming from the community, you know what are the probable reasons of the acute febrile illness. And when I say setting, setting is the epidemiology, the current epidemiology that the child is being seen in. Say, for example, a febrile child coming in this era, one would definitely think of COVID while keeping in mind other differentials of acute febrile illness. And then enough has been said about the importance of a detailed history, talking about the origin, duration, and progress of the illness and associated symptoms, which would definitely again help you in shortlisting your differentials. And then do a thorough clinical examination. One must make an attempt to rather not forget to have focused local examinations of areas like throat, ear, which sometimes in a busy practice we tend to overlook. And then finally, the working diagnosis will lead to the list of investigations that you would ask. Now let us look at this 18-month-old girl who has come with fever of 2 days. Talking about immune status, this is a child who has never had any illness in the past. So she's a immunocompetent child coming from the community. And we are in the COVID pandemic. So could this be COVID? Yes, certainly this can be COVID. And we know that COVID in a child could have fever or with or without GI symptoms like loose motions, vomiting, abdominal discomfort. Some may have respiratory symptoms like cough, cold, sore throat. Some have influenza-like illness, even with low respiratory involvement. Fortunately, not as high as that one sees in adult patients, and it could just present with fever with myalgia and headache. A grown-up child may complain of loss of taste or loss of smell. But this, in nutshell, are various presentations of COVID-19 in a child. With this background, it becomes imperative to ask history of close contact with COVID patient. Given the transmissibility that we are pretty much well aware of the SARS-CoV virus, we would ask for COVID contact in the family, contact with any other acute febrile illness in the family, because not necessarily that this close contact of fever would have undergone investigation. And then, as I said, MIS is something which we start seeing after either symptomatic or asymptomatic COVID infection. So from that angle, it becomes important to ask for history of fever in past 12 weeks, rashes, red or lips or red eyes, and loose motions, because we know there are different subsets of MIS, which Dr. Balasubramanian would allude to in his presentation. And also, it is important to know that these symptomatology that I enlisted of COVID is shared by many other tropical infections that I enlisted in the beginning: typhoid, leptospira, malaria, dengue, scrub typhus, so on and so forth. And from diagnosis and management point of view, it is important to also ask for comorbidity if at all there is in any child. I'm not talking about this child is a healthy child coming from the community. And it is also prudent to know the family details and the housing details, because that would help you to decide on where to manage the child and how to manage this child. Now, this child is immunocompetent child. We are seeing in the era of COVID pandemic. So we would go into the details of the fever history. And I cannot just lose any opportunity to impress upon the colleagues that it is so very important to ask for degree at onset of fever, interfebrile period where the child is fine or sick, response to paracetamol, and trend as the fever progresses. And this small bit of information, it gives it is of such a great help to delineate a seemingly bacterial from a non-bacterial infection. And trust me, friends, if you follow this systematic approach while eliciting history, it is very, very possible to differentiate a bacterial from a non-bacterial illness in your practice. And then again, as I said, given the overlapping clinical features, one must ask for other history, which for the differentials that you have entertained in your mind. Like in malaria, you could have similar cases in the family, or malaria cases occur. For example, in Navi Mumbai, we've already started seeing cases of malaria. I have a couple of children already admitted, one with falciparum and the other one is with Vivax malaria. Dengue cases have started coming in. Last year, during the first wave, we did not see much of dengue. But this year, yes, with the monsoon setting in, cases of dengue have started coming in. So we'll definitely ask for dengue cases in the community. And once we start seeing dengue cases, the word goes around in the amongst the colleagues that, yes, we have started seeing dengue. So one has to keep in mind this epidemiological information, ask for rash, history of joint pains or arthralgia, and puffiness, less urine, listlessness, indicating a possible leakage. Then typhoid vaccination history, the number of doses that the child has taken, if there is a history of travel or a history of eating food outside, and then wading through accumulated water, severe myalgia. If you have heard about cases of leptospirosis, I mean, this sort of basic information would definitely aid in arriving at a clinical diagnosis. And scrub typhus, friends, is very often underdiagnosed. And it's a regional disease. Some parts of our country, and I'm sure Dr. Bala would agree with me, that in the southern part of our country, they see a lot of scrub typhus. And very often on clinical ground and suspicion, they use anti-scrub typhus antibiotic in such children. Again, Ishkar, which is sort of pathognomonic feature of scrub typhus. As I said, you need to look out for clinical features which would give you a clue to underlying illnesses like malaria, typhoid, leptospirosis, scrub typhus, or dengue. And then you also need to look out for specific signs in the child for, say, coated tongue or a just palpable skin typhoid patient, suffused conjunctiva, severe myalgia. Look for intertriginous area for eschar, presence of eschar. Then pallor, maybe icterus or spleen in malaria cases, rash, evidence of leakage in the form of puffiness, hepatomegaly, tender hepatomegaly, reduced air entry on the right side, indicating a possible accumulation of fluid in the pleural space. And then this would guide you to your underlying investigation. Now, a point to make here is most of us are now into virtual consultation and over telephone or video, WhatsApp video, or we use different platforms. And let us, this systematic approach is even more important so as to, shortlist a few differentials and then ask the patient to visit a nearby laboratory or call them to your hospital and get them investigated for, particular differential that you've thought of in mind. So unless you follow this systematic approach, it would be difficult, and that would lead to, abuse of antibiotic, prescribing antibiotics unnecessarily. And once a panic button is pressed, we tend to get into irrational sort of practices. Patients would, over phone, would tell you that child has high fever and they were first of starting antibiotics. They tend to use irrational antibiotics as well. So let's not get into that. And I understand that patients are finding it a little difficult or they are skeptical about visiting a healthcare setting. However, we must ensure them that the adequate measures are taken at hospitals so as to prevent infection, child contracting cold infection when at the hospital. And we have, fortunately, a good network of laboratories wherein home collection is also not so difficult. And as I said, based on history, clinical information, you shortlist a few differential and do the relevant investigation. So when you have acute febrile illness in COVID times, say for example, this 18-month girl, you would ask for a COVID test. Now, talking a few principles of COVID test, whom to test, when to test, and which test to do. If you look at the Indian Academy of Pediatric recommendations, ideally, every child with suspected AFI should undergo COVID testing. But there are constraints, and it is not possible. It would unnecessarily stretch the resources to unimaginable extent. So, what is also said that testing may be deferred if the child has mild symptoms and has no comorbidities, or if there is a known family member who is having COVID. So, in such instance, avoid testing such a child if resources don't permit. However, testing would make it very easy for you to counsel the parents on the importance of isolating the child, or at least isolating the at-risk members in the family, asking them to keep away from the child and ask them to wear mask in the family. When to test? The day of onset of symptom is the best time. And as the disease progresses, the sensitivity keeps dropping. Which test? Antigen test is very easily available. In a symptomatic child, if antigen test is positive, you take it as COVID. If it is negative, you have to follow it up with the RT-PCR. And mind you, friends, neither test is 100% sensitive. We know at its best, the RT-PCR on the nasopharyngeal swab has about positivity or sensitivity of 60-70%. And antigen test, it is claimed by ICMR that these newer antigen tests have sensitivity to the tune of 74%. But trust me, in a child, it becomes difficult to collect the swab. And I really do not know whether we would be able to hit such a high sensitivity in clinical practice. Specificity, all these tests are good rule-in tests. They are not good rule-out tests. A positive would tell you that, yes, the child has COVID, but a negative test would not rule it out. And CT value. By CT value, I mean the cycle threshold and not the CT chest. The cycle threshold value is being talked about, but let me reiterate that at best, it tells you the timing of infection. And lower the CT value, higher the load is applicable for that particular moment when the swab is taken. And it has so many other factors influencing the estimation of CT value. So please refrain from using CT value to prognosticate or adjust the severity of illness. So if you have a child who tests positive, you would obviously triage and manage the child as per the severity of illness. If the child is negative and the suspicion of COVID persists, there are a few, if you have a very close contact, child has fever, myalgia, and you have ruled out any other, condition clinically, you may have to ask for a repeat test. At this time, it could be RT-PCR if you have done an antigen before. And if it is positive, again, you would try and manage as per the severity. And if the suspicion is low, or if your repeat test is negative, then this is the time you must, once again, look out for signs and symptoms of other acute febrile illnesses like malaria, dengue, leptospira. And I have already enumerated the clinical clues that one would look out for in a child. And then, fortunately, we have a battery of tests. Some of them are rapid tests, and most are available in all parts of our country. Say, for example, a good peripheral smear. Ask for a thick smear which would improve diagnosis at tenfolds, and followed by a thin smear to identify the species in a child who has, say, pallor or has spleen, or a child who comes in encephalopathy in an area where malaria cases have started coming in. And you could also resort to doing rapid malaria antigen test. In a child where you suspect dengue, I don't have to discuss this with my learned colleague that NS1 has fantastic sensitivity and almost 100% specificity, especially when done in first 3 to 4 days of illness. And then if the child comes a little late, you can do dengue serology in the form of antibodies. And very often it becomes difficult to know the exact day of illness. And there is a recommendation that you do a triple test. Ask for antigen and the antibody, both IgM and IgG in the same sitting. Look for rash, scar, and if your suspicion for scrub typhus is high, scrub IgM is available. You can ask for lepto-IgM. However, one could use the Fiennes criteria, and in the epidemiological setting with the clinical impression, one could really administer anti-lepto antibiotic. Fortunately, ceftriaxone, which is used rampantly, rather abused rampantly, does cover leptospirosis. And then for in the regions where cases of chikungunya are seen every year, please be on lookout. You could ask for chikungunya IgM, or now you have tropical fever panel where molecular tests like PCRs are available. In a sick-looking child, it's a good practice to send a blood culture on day 2 or day 3 of illness, and then try to make a diagnosis. Coming back to our case, this 18-month girl had fever for 2 days, was previously healthy, COVID contact in mother. Mother had COVID, which was diagnosed 4 days ago. The mother is asymptomatic now. And there is father, another 5-year-old sib, and grandmother staying in the 2 BHK, those 2 toilets. And the child's SARS-CoV-2 antigen is negative. Grandmother has taken 2 doses of vaccine. It is important to ask this vaccination history because that offers some degree of protection, especially against severe disease or hospitalization. So what do you do next? Obviously, this child would be, every child need not be admitted. Since we are in COVID era, let me talk a little bit about how to manage a COVID child. with acute febrile illness, you would isolate this child for 2 weeks at home. Grandparents and all other members at risk. There could be a sick with chronic disease. These members need to stay away from the child. All the family members should wear masks. Fortunately, if you have this kind of COVID test positive in a child with acute febrile illness and you have reasonably ruled out other AFI on clinical grounds, you did not ask for any laboratory test, or there is no antibiotic which is required, paracetamol for fever, and use rational symptomatic medication, look after the child's nutrition, and educate the parents on monitoring this child at home in terms of temperature, pulse, the respiratory rate. Train them how to count respiratory rate by keeping the hand on the tummy and looking at the excursions, and then monitor saturation if the child is old. At the same time, cautioning the parents not to panic, because we not uncommonly get phone calls from parents of very young children where they apply the pulse oximeter, which is used for adults, and they call you in panic that the saturation is 70% and 80%, and on video you see the child absolutely playful, active, and kicking around. Monitor for urine output, watch for red flags, and these are the red flags that you're going to talk to your parents about: drowsiness, lethargy, red eyes, persistent fever beyond 3 days, or the child is passing less urine or dark urine, which, let me tell you friends, please do not forget our old friend dengue. A child with leakage can manifest with dropping in urine output and passing dark urine, rapid and difficult breathing. These are the red flag signs which the parent should be educated on, and they must be asked to connect with you as soon as they see any of the red flag signs. Please look for comorbidities, and if a child has any of these comorbidities enlisted here, immunocompromised status, chronic disease of any organ, diabetes, or obesity, you must have a low threshold of admitting such a child so as to monitor it better, because these children are at risk of complicating the COVID illness. And then this child was advised all this. This child started having bad loose motions, which became watery. Child started vomiting, started passing less urine. The child parents contacted on the phone. The child was initially asked to come to the hospital facility. Now this time, you remember, this child had a negative COVID antigen test. However, as the other AFI were reasonably ruled out, so we repeated a RT-PCR test next day, and it came positive, and this child was shifted to COVID facility. Now, most of the nursing homes do not have luxury of having a COVID suspect area and COVID area and non-COVID area. So we have to see that we delineate some part of our nursing homes to hold such suspect cases, unless until such time that the reports are available. And then this child now falls in the category of moderate COVID. She is maintaining saturation. And then in moderate COVID, hospitalized patient, these are the only few investigations that one would ask for: CBC, CRP, HGPT, creatinine, electrolytes, albumin, and X-ray test. This child had more or less normal reports on all these fronts, and this child was monitored further in hospital, given IV fluids, paracetamol, zinc, and no antibiotics were used. So the role of the first contact doctor, which is pediatrician in most of the cases these days, is to suspect, test, do the relevant test at appropriate timing, and try it. If the child has mild disease, you manage the child at home. Moderate disease should be referred to a COVID facility. If it is a severe COVID, obviously the child would be sent to an ICU facility. Now I'll quickly walk you through two cases that we saw about a month ago. This is a 12-year-old child weighing 56 kg, fever for 5 to 6 days, mild cough, and parents said that the child feels breathless. However, on the exam, the child was not breathless. There was no tachypnea, and the SATs were 98% in room air. And the parents came with this X-ray, which was done outside, which showed peripheral opacities. And there was a big panic, especially on the background that father had COVID 2 weeks ago. We ran through some basic investigation. All the investigations were normal, near normal, as shown on the screen, except the counts which were marginally high. However, the child was afebrile, maintaining saturation room air, and had come with this X-ray. So we labeled this child as perhaps he was febrile for 5 days, some X-ray changes, but maintaining saturation. So this is a moderate COVID with no hypoxia and no comorbidity except little overweight. This child was admitted in COVID facility, was observed, and was given only symptomatic treatment. As against that, we have this child who is a 12-year-old child weighing 75 kilograms, having fever for 4 days, touching up to 103, loose motions for fast 3-4 days. Child started having dry cough. Intake was very poor. And unfortunately, the child had lost his father a few days ago, whose RT was negative. However, the postmortem had revealed pneumonia. So this was a possible or probable COVID contact. This child was hypoxic, was unable to maintain saturation in room air and required oxygen. This child also had acanthosis nigricans, 75 kg, 12-year-old, very obese child, and the blood sugar on admission was normal. Had bilateral lower lobe and right upper lobe patchy consolidation on X-ray. Somebody had done a CT, and CT gave a score of 4/25. His TrueNAT SARS-CoV PCR was positive. So this is a child who has moderate COVID disease with hypoxia and was unable to maintain saturation in room air. So this child was administered oxygen, was given dexamethasone, and was used remdesivir. This child came about 3-4 weeks ago, and there was an advisory to use remdesivir. Now the WHO and the IAP has come out with very clear advisory on when to use remdesivir. I would not go into the details. However, unless you have child coming within a week of illness, child who is hypoxic requiring oxygen, and you have confirmed case of COVID on compassionate ground, one could use remdesivir in such children. Friends, let us not forget our usual infections. Here, I'm going to show you a few cases where we were about to treat these children as MIS, but we observed patients, we went into the investigations and the clinical examination, and we did not use steroids or IV in these children. This is a 3-year-old boy who presented with high fever of 3 days, was given symptomatic treatment. His COVID RT-PCR was positive. The other family members were also positive. This child had high count, about 16,000, with neutrophilic predominance, very high CRP, 200 plus, ESR of 67, had high ferritin. However, the urine showed packed filled pus cells. Given the COVID RT-PCR positive status, this child was hospitalized in COVID facility. The urine showed packed filled pus cells, nitrites were positive. We sent urine routine examination, urine culture was sent, and it grew ESBL E. coli. So this child was treated, but until we had this report of urine packed filled pus cells and the culture report, we were in a big dilemma whether to call this multi-system inflammatory syndrome and whether to jump to giving immunoglobulin or steroids. Remember, friends, there is a big dilemma, and we do cases where differentiating a sepsis from MISC is not at all easy in many situations. And Dr. Bala would elaborate further on this dilemma. Here you have a 3-year-old girl, again high fever and loose motions for 3 days, was given syrup cefixime, COVID RT-PCR positive, counts of 10,600, neutrophilic counts, high CRP of 120, ESR was 40, ferritin levels were high but not very high, urine routine was normal. This child also had this, say, mucositis. One starts imagining red lips, chapped lips, and COVID positivity. And trust me, we consulted a rheumatologist. We were about to start this child on steroids and immunoglobulins, but fortunately, given the teamwork that we do, we decided to. Since the child was not in shock, we chose to wait for 24 hours, and came the report of paratyphy. So, friends, we must not forget the usual cause of acute febrile illness that we see in practice. We have been seeing in practice for the last several years. And let us not overdiagnose MIS or COVID in such situations. And finally, this 11-year-old boy with high fever, giddiness, vomiting, neutrophilia, this child gets admitted, gets a seizure after admission. We did a CSF which showed 300 cells, 70% neutrophils. COVID antibody positive. We sent this sample to NIV Pune, and the Japanese encephalitis IgM was positive. So here we had a child who presented with fever, seizures, and delirium, and the antibodies were positive. Similarly, we had an 8-year-old girl with acute abdomen, right iliac fossa tenderness, USG suggests appendicitis, COVID antibody positive, and this child had a perforated appendix. Child also had supramesenteric vein thrombosis. The ferritins were high. This child's mother had hypercoagulable state in the past, had DVT. So we are increasingly getting cases of your regular infections and acute febrile illnesses where antibody positivity is increasing. And it becomes difficult to, say that the current state that the child is caused by COVID or just the COVID antibody is a silent bystander. So one has to observe caution before labeling a child as MIC or COVID illness before applying treatment. Now I would conclude with this last case of Yewale, 2-year-old boy, because Yewale is a very, very common presentation of your SARS-CoV or COVID. And since last 2 weeks, at least in Mumbai, we have started getting lots of cases of your usual viral associated disease, bronchiolitis, and a few cases of pneumonia. This child of 2 years came with fear of 3 days, cold and cough for 3 days, was tachypneic, had a few crepitations. Normal counts, CRP negative, SARS PCR is negative. The child was starting oseltamivir given the fact the child had acute febrile illness, influenza-like illness with low counts and a negative CRP. Was also given symptomatic treatment. And we had the luxury of sending BioFire nasopharyngeal swab, and this is what it showed. It detected respiratory syncytial virus. So again, the point that I'm trying to make is, at least in Navi Mumbai, we have started getting lots of cases of bronchiolitis. So let us not call every child with ILS as COVID. Yes, as a policy, it is imperative to test such children for COVID. However, the point that I'm trying to make is, with the monsoon setting in, we have already started getting cases of your usual acute febrile illnesses that we used to see in the past. So fever, cough, rapid breathing, let us not forget our basic approach of, delineating your asthma, bronchiolitis valvi from pneumonia, which would require antibiotic. And obviously, all these children would undergo testing for SARS-CoV-2. However, let us not label each child as having COVID, and let us be very firm on our basics, and let us not miss out on our usual AFI illnesses. So I would conclude with this algorithm slide. AFI, do COVID test, positive triage and manage as per severity. If it is negative, suspicion of COVID persists, repeat a test. If it is positive, manage according to the severity. If the test is negative or the suspicion of COVID is not high, look for signs and symptoms of other AFI, jaundice, pallor, spleen, encephalopathy, do PS for malaria or do RDT, rash, spleen, leukopenia, low platelet, cases in the locality, think of dengue, ask for NS1 or dengue antibody depending on the day of illness, rash, eschar, think of scrub, or you may even start anti-scrub medicine empirically, congenital suffusion, jaundice, AKI, acute kidney injury in the form of low urine output or elevated creatinine, think of leptospirosis. These children may have aseptic meningitis also. Rash, arthralgia, leukopenia, think of chikungunya. You may ask for IgM or PCR. And sick look child on the child, just palpable signs of typhlitis, coated tongue, think of typhoid, ask for blood cultures. So this is how, if you have a systematic algorithmic approach, one would arrive at a definitive diagnosis and do justice to the patient. Friends, let us not discontinue the non-pharmaceutical measures of social distancing, wearing masks and sanitizing. And to add to this, SMS is now we vaccinate and encourage your parents, the parents of the patients, to take COVID vaccine. With this, I would end here, and we would take question answers at the end after all these 3 talks are over. Thank you very much. Over to you, Dr. Nidhi.